Thank you, Alejandro, again. The next speaker is Fadi Fakhouri from Lausanne, who is an adult nephrologist and a clinical researcher who has a long-standing interest in autoimmune renal diseases, particularly the complement-mediated nephropathy, which we'll talk about today, and also the thrombotic microangiopathies and C3 glomerulopathy and also glomerulonephritis.
Thank you. Okay. I don't think it's working. Okay. Thank you. Thanks, Franz, for the invitation, and thanks to Stephanie and her colleague for all the help. So I was asked to discuss complement disorders affecting the kidneys in view of innovative therapies. So it's going to be a very clinical perspective. So do not expect neither Western blots nor confocal microscopy images. I'm basically and hardly a clinician. These are my conflict of interest. So the story with complement inhibitors started in nephrology with atypical HOS, as you all know, and with PNH outside nephrology. And the story started with C5 blockade with eculizumab, as you all know, and it has initiated the development of a new class of complement inhibitors that are currently focusing on the C3 convertase, alternative C3 convertase, and on C5 again, mostly, if not exclusively. And as you will see, there are an increasing number of complement inhibitors tested in an increasing number of kidney disease, with some targeting C5 again, other targeting regulators or cofactors or components of C3 convertase, and some targeting the lectin pathway. It's not a complete list, of course, exhaustive list, and we have some inhibitors focusing on the classical pathway, tested mostly on renal transplantation. But to be honest, the data generated from these studies are very preliminary, and we can't rely on them today to make general conclusions. Some of them are still ongoing, some has been published, and in my opinion, none can give a definite impression or conclusion regarding a single or specific complement inhibitor and a specific indication. So I will stay in more general consideration regarding complement inhibition in kidney disease. So with the emergence of this new therapeutic class, we are faced with a new major question when we are faced with kidney disease. Is it complement mediated? It's true for kidney disease, but it's also true for extra-renal disease in which complement role is suspected. And to be honest, to detect and to assess whether kidney disease is complement mediated, we have to date no golden test, positive test, that when you take the serum of a patient can tell you, well, it's a kidney disease complement mediated. We have direct and indirect arguments, starting with the detection of complement activation markers in the circulation and or urine or within kidney tissue. For example, serum level of several complement components, and of course, the detection of complement deposition in kidneys. One first comment, we should not to date overestimate the clinical significance of complement circulating biomarkers. I'll go back to this a little bit later. The second set of argument is the detection of genetic or acquired complement dysregulation, complement gene variants, or autoantibodies targeting the complement, mainly alternative pathway. But once again, one has to keep in mind that rare pathogenic complement variants are present in healthy population, around 3–5%. Second, not all variants are pathogenic. And third, complement gene variants are only risk factors. We are not discussing, like the previous disease, monogenic, clearly monogenic disease. We are discussing genetic susceptibility to kidney disease or an amplifying factor or effect of complement activation. The third, of course, is the benefit of inhibition modulation of complement system in animal models, but as already said, it cannot be always easily translated. And finally, of course, the reversibility of or marked clinical improvement of a kidney disease with complement inhibition, as we have seen with atypical HOS, and as we are expecting with the ongoing studies with other complement inhibitors in various diseases. This is the first set of arguments. And based on these arguments, we can roughly classify kidney disease in 4 different distinct types of complement-mediated disease. I will start with glomerular disease. The first type is glomerular disease in which the predominant or exclusive deposition, immune deposits in the kidney are complement deposits. Of course, the prototypic is C3 glomerulopathy, but one should not forget that acute post-infectious glomerulonephritis is also prototypic C3 glomerulonephritis, but is usually spontaneously reversible. The second is nephropathies with immunoglobulin or immune complexes and complement deposits. And in this set of disease, it is supposed that the triggering event is immunoglobulin deposition with an amplifying effect of complement. I'll go back to this a little bit later. The third type is disease where there is no specific complement-induced inflammation. There's no complement deposition. The example is ANCA vasculitis. And we know today that especially C5a has a loop of activation of neutrophils, but maybe we neglected it, but we didn't suppose that this disease was mainly complement-mediated or characterized by predominant complement deposition in the kidney. And the last one is complement-mediated TMA. I'll put it aside because it's very peculiar. You have an anterior injury mediated by complement. It may be not specific. Why it's targeting specifically the kidney, it's remain a question unsolved. But still, roughly all kidney disease can be organized or put in one of these categories. But one should not forget that complement is also involved, maybe not specifically, in other aspects of kidney disease. For example, you have very convincing and significant data from Remoudi's group showing that, for example, proteinuria by itself induced tubular and interstitial damage through complement activation and stabilization of properdin and cysteine convertase at the surface of endothelial cells. And of course, the role of complement in ischemia reperfusion following renal transplantation or hypoxia during shock complement is involved mainly in ischemia reperfusion in a very predominant way. And when we go into distinct disease, we see that the level of evidence of complement involvement and the strength and the weight of complement involvement varies very widely. For example, you take C3 glomerulopathy, we probably all agree that complement alternative pathway dysregulation is one of the major, if not the only, but one of the major driver of the disease. Acute post-infectious glomerulonephritis, and then you go to other disease where there is no significant, for example, genetic complement dysregulation detected or autoantibodies, which is true also for C3 glomerulopathy, but at least, for example, for lupus nephritis, you have convincing experimental and clinical data showing inactivation of complement, including the final pathway of complement in severe lupus nephritis. ANCA, I will not go into all these details, but one example, for example, you take atypical HOS, before the detection of complement gene variants in atypical HOS, nobody suspected the role of complement in atypical HOS. You had no complement deposition significant in the kidney, and the story started with some patient having low C3 levels and then discovery of factor H variant. So probably there's a gradient in complement involvement. And probably for good reasons, we started with disease where complement role was so predominant, it was so easy, fortunately for patients, to see an effect. But even with the two primary diseases, PNH and atypical HOS, there's some major differences. PNH, for example, is a clonal complement dysregulation present in all patients, whatever. You have all carriers develop the disease, you have a positive diagnostic test, you stop the treatment, disease relapses. In atypical HUS, you have a lot of healthy carriers, you have no diagnostic test except in patients in whom complement gene pathogenic variants are detected. A response to treatment can be assessed within weeks or months compared to a couple of days in PNH. And when you stop treatment, relapse does not follow in 100% of cases. And when you go to even to C3G, it's even more complex. You have not a high incidence of complement gene dysregulation or complement gene variants. The phenotype of the disease is very heterogeneous compared to the two previous diseases, and response to complement blockade should be assessed within months, if not years, especially in terms of end-stage disease, which was reassessed rather than 6 months for atypical HUS, which was more explosive disease. And finally, when we move outside this disease, for example, let's say IgA nephropathy, and there's a rush towards the IgA nephropathy with complement inhibitors, probably it's going to be very hard to see a clear effect. Maybe it would be harder than in the other disease. So to make it simple, I'll try to summarize some, it's not the 10 commandments, but some general consideration regarding complement inhibitors assessment or use in kidney disease. The first is that the inhibition of the complement alternative pathway is a potential treatment for kidney disease primarily driven by C3 degradation product deposition. Well, it's rather agreed for C3 glomerulopathy, but within this approach, you have some variation. You can target cofactors of C3 convertase, factor D, or one component of the C3 convertase. You can target directly the final pathogenic product C3b, and each approach has its plus and minus sides. One more point. We all agree today that atypical HUS, for example, is due to dysregulation of C3 convertase, but still we are targeting the C5, which is downstream. Maybe one approach would be to target directly the C3 convertase. The second point is that complement alternative pathway inhibitors with enhanced potency may represent potential therapeutic agents who are focusing a lot on inhibiting something, but some companies are working on enhanced factor H or enhanced factor I. There has been a discussion about recombinant factor H that has started almost 15 or 20 years ago. And inhibition of the initial phase of the classical and lectin pathway is a potential treatment for immunoglobulin and immune complex mediated kidney disease. Well, it may be an option, but one should keep in mind that the C3 convertase and the alternative pathway is also an amplifying pathway for complement activation initiated by the classical or the lectin pathway, which means that even in disease driven by immunoglobulin or immune complexes, maybe the alternative convertase may still play a role. And in some disease, we are still not very sure of the pathogenic role of immunoglobulins. You take, for example, immunoglobulin MPGN, and there's a lot of discussion today whether it is or not distinct from C3 glomerulopathy, but when you look to the evidence, there are much more evidence pointing towards an activation or an overactivation of the alternative pathway than the classical pathway, even in immunoglobulin-mediated MPG. Fourth, C5 and C5a blockers may represent an alternative to corticosteroids as more optimal anti-inflammatory drugs. And I believe this is one way moving forward. It has been more or less shown in ANCA vasculitis, where avacopan, an oral anti-C5a antagonist, was at least as efficacious as prednisone and helped decrease and save a lot of cortisone to patients and maintained remission more efficaciously than prednisone, but as long as patients were still receiving avacopan. So C5a receptor antagonists or even C5 are currently tested in lupus nephritis, and maybe in the coming years, in all glomerular disease where you need an anti-inflammatory drugs, these agents may replace corticosteroids. One of the major diseases where there is still is lupus nephritis. As you know, lupus nephritis, the rate of complete remission is around 15, 25%, 30% if you are very optimistic. So we still need to improve the quality of renal remission, and maybe this complement inhibitors will help improve the rate of complement renal remission. Constitutional complement alternative pathway circulation is only a risk factor, which goes back to what I have said and what have been discussed previously regarding gene therapy in these patients. And in hemoglobin and immune complex-driven kidney disease, the primary therapeutic target is immunoglobulin or immune complexes production and not complement inhibition. For example, in ANCA vasculitis, of course, avacopan will not replace cyclophosphamide or rituximab. It may seem obvious in ANCA vasculitis. I may remind you with the first approach, for example, of antibody-mediated rejection of kidney transplantation, where eculizumab was rather tested as a unique treatment for antibody-mediated rejection, where in reality it was just buying time to give a chance for immunosuppressive drugs, including rituximab or other drugs, to decrease the DSA levels. So, 6, for complement-mediated kidney disease, distinct complement modulators may be required during the acute and chronic phase. One example is atypical HOS, for example. In the induction phase, you are not sure 100% it's atypical HOS. So, in my opinion, it would be more adequate to use short-term acting C5 inhibition. Whereas in patients who should be maintained as a long-term on C5 blockade, maybe long-term C5 inhibition would be a more optimal option. This is true also for C3G. As you know, C3G, as in several kidney disease, you have on one side deposits, on the other side, in some patients, inflammation, including IgA nephropathy. And maybe some patient will need anti-inflammatory drugs with anti-complement, let's say anti-C5, other would need anti-C3 convertase to reduce deposits, and maybe some of them will need both or one followed by another, depending on what phase of their disease they are in. Next, the potential clinical benefit should clearly outweigh the infectious risk resulting from the inhibition of complement cascade components. Well, we did not have, fortunately, a lot of infectious complication with eculizumab. But this was also due to the fact that we knew that vaccination is not 100% protection, and most countries keep antiprophylaxis during treatment. And I would say that the benefit should also outweigh the costs. We started with PNH and atypical HOS, very devastating disease. When you go to some forms of IgA nephropathy, where the loss of kidney may take 15, 20 years, it's not probably the same balance between the benefit, the cost, and the risk. And the clinical relevance of anti-complement autoantibodies for the use of complement blockers is not established. This goes back to what I have said earlier. We should not put a lot of, I think it's written here, we should not put a lot of weight and importance on complement biomarkers for testing new drugs. We don't know which drug is going to work in which patient. So, for example, selecting patients with high soluble C5 benign levels in serum to test an anti-C5 may be intuitive. It has not been proven to be predictive of response to treatment, including with eculizumab. So, one should be very cautious, especially in the design of clinical trials, not to rely too much on biomarkers. And complement genetics may help us individualize the optimal duration of anti-complement therapy in a given patient with a given kidney disease. Well, this has been more or less helpful in atypical HOS, where today, roughly in patients with no complement, the pathogenic complement gene variant detected, the risk of relapse after discontinuation of C5 blockade is very, very, very low, below 5%, which means that genetics and the assessment of expert of genetics has become paramount, for example, in the treatment of and the management of patients with ARKNet, and those with no complement gene variants probably can safely discontinue C5 blockade, whereas the others may choose to remain and maybe should be advised to remain on long-term C5 inhibition, and patient decision is very paramount in this discussion. Finally, the selection of the optimal target for complement inhibition should be individualized and integrate the patient-specific clinical characteristic, complement biology, genetic profile, and kidney pathologic data. Sometimes we are focusing a lot on complement biomarkers, and we forget that to date, one of the best biomarkers in nephrology is kidney pathology features, especially for the progression of kidney disease. And the approach Beppe-Rimuti's group and Marina's group had with a clustering of patients based on several aspects of this disease, for example, for C3G, including clinical, complement biology, genetic profile, and kidney pathology, may be very helpful. Finally, I will conclude saying that complement system is very old, very well preserved, and is very tricky. And when we start messing with such redundant and preserved system, we may have some surprise. For example, you take a model of C3 glomerulopathy in mice, and you postulate that if you remove properdin, you will improve the disease because properdin is the only known stabilizer or amplifier of the alternative C3 convertase. And it turns out that you worsen some aspect, if not several aspects of the disease, because you switch off the C5 activation and everything turns towards C3 activation. This is the postulate. But it was a very bad surprise for mice, and probably it stopped the development of specifically targeting properdin in patients with C3G. So, complement modulation in kidney and extrarenal disease, because the story started with kidney and a little bit PNH, but it will go to, it has already started with other disease. We now have very powerful tools, but complement cascade is an old and complex system. And enthusiasm with this new approach and this new therapeutic class should not preclude caution. Thank you. I would be more than happy to answer your question.
Thank you very much for this nice overview. Any questions? One.
Yeah, no, really interesting. So it'd be interesting to know what your views are on systemic complement blockade for a disease that affects predominantly, cell surface complement regulation, and how well does it get there, target it? What are the factors that influence that?
Yeah. When complement activation is systemic, we don't know why it does so much damage only in the kidney. But there are some approaches to target complement inhibition to sites of inflammation, for example, with all the CR1 factor H hybrid genes. Honestly, I think that systemic inhibition will be still more efficient, maybe more dangerous, but it will be more efficient. But I have no more experience with targeting specifically at the in the kidney. I don't know. Probably with the CR hybrid genes, targeting inhibitor, for example, factor H plus CR1, targeting and delivering factor H to the site of inflammation, maybe it's an option, but I have no experience.
So just to follow up on this, you have a slide on the tubular complement activation, and the complement cascade was inside the tubular lumen. How do they get there? Are they filtered, or?
Some are filtered, some are synthesized within tubular cells. We know today that tubular cells synthesize C3, properdin, even factor H, and following exposure to proteinuria, some of them also down-regulate at their surface some inhibitors of the complement, like MCP. You have a local synthesis.
Yeah, in the back.
Thank you for your excellent talk, but you were mentioning the safetiness of interrupting the blockade. And if I look at that, and I mean, there's rational, especially also for the price and whatever it is, but if we are looking to the Maastricht paper, who identified chronic hypertension, vasculopathy, how sure are we that with the limited follow-up that we are having, that we do not have a subclinical atherosclerosis who's developing by chronic activation?
It's a very interesting question, a very good question. I said it is safe in patients with no pathogenic variant. Those in whom we assume there's no continuous low-grade activation. The Maastricht experience, in my point of view, has been presented not in the proper way. In my point of view, it was atypical HOS diagnosed very lately or undiagnosed, and I would term them complement-mediated atypical HOS with hypertension. But I fully agree with you. In patients with complement gene variant, especially pathogenic complement gene variant, factor H, C3, factor B, and to some extent factor I, and even I would add MCP. I don't know what is the long-term effect of repeated relapse of disease, especially in MCP patient. And one cannot exclude that in this patient, subclinical complement damage can continue, and you may have some progression of CKD even without overt relapse of the disease, and even you may have extrarenal manifestation due to continuous. I don't know. You are right. One should be very careful in this point.
There an ongoing study in children with C3 glomerulopathy that is no longer off-label use for eculizumab. That's a question of the parents also.
I'm aware of studies open to adolescent patients, but not starting 12 years old. And Marina can correct me if she wishes. But the Apelli study is open to adolescents starting 12 or 13 years. But I'm not aware of younger ages.
The ERKNet study enrolled 12 to 18, but it's now closed. The Apelli study is open and enrolling 12 to 18. The ERKNet study is about to open. It will open in the beginning of 2023 to 12 to 18.
Okay, I think we have to move on to the next talk. So next speaker is Francesco Trepiccione from Naples, where he's an associate professor in nephrology at the University of Catania. Francesco did his PhD in Denmark at the Salt and Water Research Center at Aarhus University, where he obtained a strong background in renal physiology. Then he also did a postdoc in Paris, where I also got to interact with him. And now he's back in Naples, or he's in Naples now, where he's studying rare renal diseases such as renal tubular acidosis, diabetes, nephrogenic diabetes insipidus, and also the glycogen storage disease that he will talk about today. The floor is yours, Francesco.
Just switch it on.
Okay, thank you, Matthias, for your kind introduction and for inviting me here. We can go back to the metabolism, and my presentation will go through a general overview on the glucose transport and metabolism in the kidney, and then we will see the effect at the preclinical level of the SGLT2 inhibitors in two glycogen storage diseases, 1B and 11. The proximal tubule is the longest segment of the nephron. We call all PT cells the ones that are lining this segment, but actually they are kind of different in some transport function. And beside the bulk of the reabsorption is made by these two segments, S1 and S2. S3 is also some secreting activity. Regarding the glucose, the majority, the bulk of the glucose filtered is reabsorbed in these two segments, but S3 is also some additional and very high affinity for glucose transport. The glucose transport machinery is composed by this SGLT2, that is a glucose coupled to sodium transporter, that mediate the intake of glucose along the S1 and S2 segment. This glucose is quickly and rapidly transferred to the basolateral membrane, where through this GLUT2 facilitator transport goes to the bloodstream. So basically, the proximal tubule cell is not fueled by glucose, but this is just quickly transported. The real energy fuel for this cell is made by free fatty acid, glutamine, and lactate. And this is even, used to start a new glucose synthesis, the gluconeogenesis, in the form of glucose 6-phosphate that is actually transported through this guy here, glucose 6-phosphate transport in the endoplasmic reticulum, then is dephosphorylated by this phosphatase, and then again going on the bloodstream. This is a very important clinical relevant new glucogenesis, since it accounts for 25% of glucose neoproduction during hypoglycemia. And only one other cell type can do that, the hepatocyte. So as you can see, the kidney is also a very important metabolic effect. And all the impairment of these part players here is clinical relevant because it gives rise to disease. The glycogen storage disease 1B, when G6PT is deficient, 1A when the phosphatase does not work, and 11 when the GLUT2 transporter is not working properly. And of course, when proximal tubule does not work properly, we have Fanconi syndrome, and you better than me knows what does it mean. This basically a complete list of phenotype can be listed here, but of course this can be variable associated. And in the glycogen storage disease, we don't have cystinosis or other form so severe, but we have glycosuria, we have hypophosphatemia, we have metabolic acidosis, and various degrees of low molecular weight proteinuria, and also of CKD progression. So the type 1B of glycogen storage disease is a very rare condition. We don't know the prevalence of this disease, that are usually handled up by metabolic guys, but it's also a renal disease. Actually, it's becoming more and more a renal disease, and I will tell you why. Actually, these patients are suffering of frequent infection and autoimmune disease because neutrophil dysfunction. They have some metabolic impairment because of hepatomegaly and glycogen accumulation, but also a kind of mild renal phenotype with Fanconi-like syndrome. But actually, by living more and more, it's the new data are appearing on the risk of develop CKD from these patients. So actually, around 25 years old, several of them need transplantation of disease. To study this, the pathogenesis of this condition, we use these mice that were generated by Alessandra Eva in Gaslini Institute in Genoa. And you can see here that this is a kind of inducible model. So when we administer tamoxifen, we can suppress the G6PT transporter. And this occurs with a very good efficiency, as you can see, in all kidney zones. So this is a kind of renal disease, not only proximal tubule disease. What we have here, the phenotype of the mice, these mice became glycosuric and present hyperphosphaturia and a low molecular weight proteinuria. And when we look at the morphology of the proximal tubule, as you can see here, is very is of high impact. The cells are completely swollen, and you can see that the nucleus is pushed up on the apical side. The lumen is almost closed. Actually, to go back in the old time, this exactly phenotype was noticed and described in pre-insulin era in diabetics. So the kidney, the proximal tubule of diabetics. And this was described in the 90s by a Napolitan anatomist called Luciano Armani, and these are called Armani lesion actually. And all the functional partners and players of proximal tubule were downregulated. So as for glycogen accumulation disease, we could see 6-fold increase of glycogen in cortical. And as you can see at EM level, this glycogen is accumulating and organizing in what is called beta particles, that are these cytosolic particles that make actually the huge, look how big is this cell compared to the control cell. And surprisingly, we could see that the whole glucose transport machinery is also reduced in the expression, and we can see SGLT2 staying only with high antibody concentration. So our working hypothesis here to try to reverse this phenotype was the following. I mean, when this guys here is dysfunction, we could see and predict that there is an accumulation of glucose 6-phosphate coming from gluconeogenesis. But would be this enough to sustain the production of all this glycogen? So we were wondering that in a way could be to make available for the metabolic pathway all this glucose that is normally reabsorbed by the cell. And so maybe somehow there could be an expression of isokinase 1 that is a crucial enzyme for starting the metabolism of glucose in the principal cell. And then this would fuel with a lot of glucose 6-phosphate the cell and make glycogen and cell swelling. We were wondering that if this was the case, by stopping the entry of glucose, the new glucose inside the cell, we could maybe make a resolution of glycogen and restore function. So to answer the first question, how is HK modulated in this system, we went back to an in vitro system and we silencing the G6PT, and we could see that both at transcript level and protein level, the expression of HK goes up together with the activity, so that somehow the dysfunction of these guys here, G6PT, is able to influence HK activity. So we treat our mice with dapagliflozin and SGLT2 inhibitors, and we could see that we prevent the glycogen accumulation, and we assist to a metabolic switch by a glycogen synthesis enzyme toward the glycogen lysis enzymes, and so this would help to remove also. Here, at histological level, you can see that the treatment really prevent this huge vaporization and swelling of the cell, and this was confirmed by a computer-based analysis of the tissue. And we could restore all the major functional markers of the proximal tubule, really by with the treatment. With high impact pictures. And of course, phosphaturia went down because now the cell could properly express on the apical membrane the NAPI2A following the treatment, while without treatment, the NAPI2 is on the apical, subapical domain. In the meantime, we were performing this bunch of experiments. Another paper came out proving that SGLT2 inhibitors were effective also on neutrophil functions. Actually, the study for neutrophils is quite different because they still keep G6PT as in the kidney, but they have another phosphatase that is called isoform Cy3 that, when it's deficient, leads to this disease, severe congenital neutropenia type 4. And this system here is mainly working as a metabolite repairing system. That basically means that is detoxifying all the wrong metabolites that can impair the function of this cell. And one of these is 1,5-amyloglycerol, that is actually a potent inhibitor of HK1. This system, the integrity of this system is really important to metabolize this and prevent HK1 dysfunction. And so the group of, a Belgian group of Maria de la Cunha proved that by applying empagliflozin, that is another SGLT2 inhibitor, they could improve the excretion, the urinary excretion of 1,5-Ag, decrease the serum and the neutrophil level, and so improving the neutrophil function. And this was done in a mouse model of severe congenital neutropenia type 4. We did it in our mice, and we could recapitulate the data. So that it was also very important for neutrophils and for these patients. And actually, currently, we have, I think, 110 patients that are treated with this condition. And actually, the paradigm that they propose is that, again, SGLT2, it cannot transport 1,5-Ag, but on S3 level, there is this two transport of glucose, SGLT4 and 5, that are also very good transporter of 1,5-Ag. So basically, the idea is that by inhibiting SGLT2, we generate glycosuria, a downstream glucose load that will saturate the transport of SGLT4 and then inhibit 1,5 reabsorption, and so decrease the circulating liver. If this 1,5-Ag has also a function in the proximal tubule cell, is not known, but likely it doesn't, since SGLT2 cannot carry in these, and also because at steady state HK is very low expressed in this cell, and this cell is not relating so much on glucose metabolism. So this is the conclusion one. We support this model and the benefit of SGLT2 inhibitors, dapagliflozin and empagliflozin, for restoring the proximal tubule function in GSD1B patients. Actually, we tested this study. Actually, we started with this condition, Fanconi-Bickel syndrome, so glycogen storage disease 11. That is another very rare disease. Actually, in the ERKNet, we collect 70 patients, I guess. And we generate a mouse model with selective inhibition of GLUT2 only in the proximal tubule, not in the liver. So this is a kidney-specific model. And these mice present with glycosuria, with polyuria, and osmotic-driven polyuria. And actually, since they have a lower threshold in glucose transporter, they perform better when we apply an IP load of glucose. As you can see here, they can excrete easily glucose. They have proximal tubular renal acidosis, as you can see here, following an acute sodium bicarbonate load. They present with higher bicarbonaturia compared with same level of plasma bicarbonate. And again, they are phosphaturic, much phosphaturic, because of lower extraction of an AP2A on the apical mainline of the proximal tubule cell. But hypophosphatemia is prevented by a reduction in PTH. With this video, I will show you how, by acquiring with two-photon microscopy, how the glucose transport is occurring in both control and knockout mice. So this is how fluorescent glucose is reabsorbed by the proximal tubule cell that became progressively yellow, so meaning that the green is getting inside the cell. And as you can see, the proximal tubule can handle all the glucose, and no glucose is seen on the distal nephron. In the knockout mice, in our knockout mice, as you can see, they have a quite different morphology. They present all these yellow dots that are likely glycogen, but they still keep some glucose reabsorption, as you can see here, but kind of lower compared to the control mice. As you can see here, in the distal tubule, we have some glucose and so some glycosuria. And when we quantify this, it's clear that the slope and the total amount of glucose uptaken is reduced in these mice compared to the control, but it's not completely abolished. And they accumulate glycogen in a time-dependent manner. So at 6 months, you see it is almost twofold glycogen accumulation, and this glycogen is here at EM accumulating in what is called alpha particle that sometimes are even surrounded by membrane. And we made some transcriptomics to see in cell what are the main pathways deranged in this system. And we could confirm that some metabolic pathway that we identified were deranged by GLUT2 ablation together with some lysosomal or autophagosomal impairment. And above all, we in single isolated proximal tubule cell segment, we could see that HK is upregulated. So the idea that, again, the working hypothesis that we follow is that maybe we could prevent this glycogen accumulation by stopping the entry pathway of glucose in this cell. And so we did treatment with 1 month with dapagliflozin that restores the glycogen to the control level, and also the phosphaturia and the bicarbonaturia together with some molecular player as NAPI2A and H3, crucial protein for proximal tubule function. We tried to translate this to patients, and so we treated for 3 months patients with SGLT2 inhibitor. This was a 30 years old patient. We were a bit afraid of hypoglycemia, so we started with 5 milligrams and then 10 milligrams. And this, of course, was made on top of electrolyte replacement therapy. And we could not see any major concern in about the safety, no hypoglycemia or IVU infection. We could see a slight increase in phosphate level. Actually, our patient was quite hypophosphatemic. This is not always occurring in this kind of patients. And this was associated with an increase in NAPI2 expression in urinary exosome. And as an exploratory endpoint, we set out the evaluation of glycogen content in the urinary cell shell. And as you can see, this went down during the treatment and then up again when we suspended the treatment. So just to summarize this bunch of work that we performed in the last few years, we have 2 models of glycogen storage disease that can mimic the patients, and that they respond quite good to dapagliflozin and SGLT2 inhibitors. We have also some proof of concept that this can be worked also for Fanconi-Bickel patients, while glycogen storage disease 1B patients are already treated actually currently. And in conclusion, so the repositioning of this drug could maybe be an opportunity for these 2 diseases. with this, I thank all the people that works in my lab and the collaborators here and the funding, of course. And I thank you all for your attention, and I will take any question if any.
Thank you, Francesco, for this great story. It's very, very nice effect indeed. And question, yeah, here, a question.
Thank you very much for an amazing talk. I would actually have a few questions for you regarding therapy in Fanconi-Bickel syndrome. In those patients that you treated as the one patient, did you observe any improvement in acidosis? Or because you only said about phosphorus, I think, and
yeah, because I show you the one that had major impact. Actually, this guy had 22 millimolar of bicarbonate and started to keep like this. So
okay, thank you. And do you expect if patients are going to be treated with this to have maybe important hypoglycemia or dehydration?
I mean, no, I could not see any dehydration. You know, there is this collection of, I think, 115, 113 patients from the group of metabolic disease, and they are GSD1B patients, and they report some hypoglycemia. But hypoglycemia is actually one of the symptoms of this disease. So if we don't apply placebo, we will never know if this is increasing or not. By the way, our patient, I mean, I have to admit that we started in the hospital. So we gave him 5 milligrams of DAPA and crazy checking the glycemia. But I mean, they are very they sensitive to this, so they actually can feel when it's coming, and they can at this age, 30 years old, can easily prevent it. This is my personal experience.
Okay, thank you.
So I have a quick question on you said that the SGLT2 is in the S1, S2 segment, and there's no expression in the S3. There's SGLT4 and 5.
And then S1, and also SGLT1.
SGLT1. So if you block only SGLT2, would you shift the glucose load to the later segment and overload them completely? Or
yeah, I guess yes. And there is where SGLT1 that is coming to reabsorb as much as possible, but actually this cannot fulfill all the glucose load. Indeed, you find it in the urine. And for the 1GA, 15AG, sorry, this actually seems to be very specific for this SGLT4 and 5. So glucose, they are low affinity for glucose compared to 1,5-AG. But when you give so much glucose, they can actually replace 1.5-AG with glucose. You know what I mean?
Yeah, but the S3 cells aren't they damaged by the?
No, not at all. No, not at all.
Okay. More questions?
So Francesco, with these really very nice results, what would be the next steps? I mean, would you consider starting a clinical trial program, or?
Franz, I'm applying everywhere to have a trial financed. We know where are the patients, because you know that we made this survey all over Europe, and actually the Italian drug agency that is supporting a no-profit study, and I mean I was 11 and they financed 7, so I'm trying with Italian Society of Nephrology. I'm trying everywhere, and maybe I have just to ask you.
And what would be the primary endpoint for a clinical trial with longer?
That's very good question. I mean, for Fanconi-Bickel, for SGL, for the 1B, actually, we could see, I think what we have to see now, beside neutrophil function, that is, I think is there, we have to see, we could see hard endpoint on kidney function. So the one that we use, like double creatinine and whatever, we could add some exploratory endpoint as we set up this glycogen measurement in the urinary set shell, and of course we could see all the other phosphaturia and blah blah blah. But I think we have to go for something like N1, because as for is clear from our survey, the only 40% are hypophosphatemic. So the phenotype is not, 100% the same for all the patients, and this is actually our common experience with all the other disease. But I would go for acid-base phosphate, but with strong endpoint, because I think it's quite safe, the drug, and so on the long run.
Okay, I think I just heard that the bus is leaving at 5:45, so I think you have to move to the next speaker. So